Okay, so um, wait, okay, okay. I think we can start, Prof. Yeah.
Yeah.
Okay, sure. Okay, thanks. Good morning. It's afternoon actually. So today we are going to talk about chronic abdominal pain and centrally mediated abdominal pain syndrome. The the thing with functional abdominal pain is we are dealing with the wiring issues, not the plumbing issues, something that not all people likes to deal with lah. So and so we are going to spend some time talking about this. So the outline of my presentation is a practical framework to approaching chronic abdominal pain, the pathophysiology of the functional abdominal disorders, and diagnostic criteria for pain predominant functional abdominal pain, specifically about centrally mediated abdominal pain syndrome and the principles of management. So we're going to start with a case study. I would like to thank Jasmine for this because she has spent a lot of time trying to summarize the case. So I'm very thankful for that. So this is a 31 years old Malay lady. She's single, nulliparous. She has recurrent colicky burning abdominal pain for many years already. Uh, the f- the last flare was actually triggered by the fructose administration during a hydrogen breath test. And apparently, during this admission, at the moment, she had severe right lower abdominal pain, but now is associated with defecation. It started since April 2025 with frequent ED visit for pain management and requires APS involvement at some point. So he is, she on and off, she will require IE intravenous morphine. Um, the thing started after surgery. So initially, she had an OST fundoplication for reflux disease, and then in 2022, she had laparoscopic appendicectomy, and the onset of chronic pain followed this. And she has allergies to a lot of things: tramadol, fentanyl, penicillin, and ranitidine, and she had family history of colon CA. Uh, sh- Her labs initially shows elevated fecal calprotectin at 101, which is slightly elevated, but the CECT abdomen and pelvis doesn't really show anything significant. And the ultrasound actually shows hepatomegaly with increased echogenicities, which is consistent with fatty livers. And the fibroscan actually shows evidence consistent with fatty liver with elevated control attenuation parameters of 300 plus. So the OGDS shows esophagitis grade 1 with hiatus hernias. The colonoscopy actually is not remarkable. But we did biopsy the terminal ileum, which shows a bit of elevation of the eosinophils. So which this is going to be discussed later with the pathologist, just to make sure that we are not missing eosinophilic colitis. And this is the images. I'm just going to put it here. And we have tried a lot of neuromodulators. She's now on amitriptyline, pregabalin, and agomelatine with variable response. She especially mentioned that the agomelatine helps a lot with the symptoms because it actually helps her to sleep. Whereas previously she can't do that, and the pain score now ranges around 3 to 4 out of 10. So based on this case, we are going to go straight into the discussion. So on and off, we are going to refer back to this case and see whether she actually fits into the diagnosis of the centrally mediated abdominal pain. So, but before that, we are going to talk about chronic abdominal pain itself because this is how most of this syndrome presents. They presents with long-standing chronic abdominal pain, and this is how the patient come to us. It will be the patient will have abdominal pain lasting for more than 3 months. It may be continuous or intermittent. But the thing with chronic abdominal pain is you always have to rule out organic causes first, or any metabolic and systemic disorders. So the common organic causes, I'm just going to list it down here: peptic ulcer disease, inflammatory bowel disease, chronic pancreatitis or malignancies, and some rare organic causes, which is median arcuate ligament syndrome, SMA syndrome, or acute intermittent porphyria, or functional cause, which we are going to discuss later. I'm not going to go into too much details in regards to how we rule out organic causes. I think that's a given already. I'm just going to have one or two slides regarding these rare causes because some people may not be aware of this. So superior mesenteric artery syndrome or SMA syndrome is caused by the compression of the third part of the duodenum due to the narrowing of the space between SMA and aorta. And this is usually due to the loss of intervening mesenteric fat pad, which is, for example, a rapid weight loss, prolonged illness, chronic bed rest, or post-surgical patients. They present with abdominal pain, which is postprandial with nausea and vomiting and early satiety, and management is supportive. Just to highlight, yeah, yeah, just to tell a story, there's a patient that I've met previously with SMA syndrome. So it's basically a young 30 years old gentleman who came in with severe abdominal pain and very, very bad vomiting, who had very bad AKI with metabolic acidosis and ends up have to be intubated and ends up have to be intubated and requiring multiple episodes of dialysis. So we have no idea what's going on, but we had a CT, which is initially reported as normal, but we actually went back to the radiologist, and they have came out with the diagnosis of SMA syndrome after the CT was reviewed. And on further history, apparently this patient is a soldier who has just gone into training, went into very, very intense training, lost a lot of weight before this patient actually came to us with this very bad abdominal pain. So yeah, so what happened is he got rapid weight loss, lost his mesenteric fat pad, and this leads to an SMA syndrome. Yeah. So a bit of clinical vignette for all of you.
Yeah, very interesting,
Yeah.
Hizami.
Yeah, yeah.
So what's the treatment actually?
Oh yeah. This patient had a very long recovery, so we actually put in an NJ tube just to hydrate the patient and just to build up the nutrition. This was when I was doing my master's all the way back in UKM lah. So he actually stayed in the hospital for almost 3 to 4 months just to build up the nutrition. So while on dialysis, he will receive TPN, and then once he's extubated, he's on NJ. We work closely with the nutrition. So slowly, once we manage to build up the nutrition, once we manage to feed him, he got better. The vomiting improved, and he can go home.
Wow. Okay.
Very very long, very very long stay in the hospital.
Okay,
Mm.
interesting case.
Yeah, yeah. And this is another interesting case. I've also seen one case previously where during my last posting. So median arcuate ligament syndrome, which is a fibrous band of the diaphragm which can press on the celiac artery and the celiac plexus of the nerves. So this can lead to the hypoposition of bowels, spleen, or livers. And the classical symptom is actually upper abdominal pain after eating or exercises, fear of eating, leading to weight loss, and the management is surgery. I also encountered a patient few months ago. It's a young lady for 35 years old who is actually working as a teacher. So for the past 6 years, he has actually been having this abdominal pain, and it's very classic. It's epigastric pain, worse after eating, and it's very, very bad, which will require the patient to be admitted, and he will have APS reviews, he will have morphines, he will have fentanyls, and after 3 to 4 days, because whenever he got admitted, she will be fasted, she will improve after that, and then she will got discharged. So she has been investigated for everything under the sun. I think she got at least 5 colonoscopies and 6 OGDS. And at some point, we thought it was IBD because the fecal calprotectin was slightly elevated. So during the last admission, she somehow, during one of the admissions, I was taking care of this patient. I just threw out the diagnosis of possible median arcuate ligament syndrome and then talked to the radiologist. So This is the image that she gave us after a close reviews. So she's the only one who caught this. So if you can see, that's the aorta, and the arrow actually shows a narrowing of the celiac trunk. So it's very subtle, and you can miss this. And this narrowing is the one that actually caused median arcuate ligament syndrome. Uh, so
Wow.
so uh so it's very subtle. So we actually referred this patient to surgery, and she is actually scheduled for a ligament release. I'm actually trying to follow up this patient and see whether we have managed to whether the symptom improve or not after the surgery.
Another
Mm.
interesting
Yeah,
case.
yeah, yeah. So so back to the approach of chronic abdominal pain. So when you're dealing with chronic abdominal pain, you need to have a detailed history, identify alarm features, have focused physical examination, some basic investigations, and the targeted imaging or endoscopy, and consider disorders of the gut-brain interaction. I'm not sure what happens, but the alarm features
Sorry,
basically
Zami, I
there's
think
eh, hello.
we lost you for a while just now.
Okay, sure. Yeah, yeah. I'm connected to the university internet, so hopefully it's going to be stable now. So first of all, whenever you're dealing with chronic abdominal pain, make sure that you have to catch the alarm features, and this is a very important point for the junior doctors. So the alarm features will include gastrointestinal bleeding, iron deficiency anemia, unintentional weight loss, persistent vomiting, dysphagia, or family history of GI malignancy, or the onset is after the age of 50. So if you have these alarm features, you have to be a bit more vigilant and investigate further and make sure that you have ruled out organic causes adequately. So this is some of the features that is suggestive of structural or organic disease in addition to the presence of alarm symptoms such as rectal bleeding or weight loss. So if it is more recent in onset, you have to be a bit more vigilant. If it is described as more sensory rather than emotional terms, if it is variable or intermittent in intensity, or if the location is very precise. For example, the patient can localize it very accurate to the right iliac fossa, for example, or is responsive to anti-motility agents or peripherally acting analgesics. If the event is related to the if the event is related to anything that affects for the gut function. For example, remember the SMA, the mouse patient, it, it is related, it is specifically related to the episode when the patient was eating, and usually associated with fewer difficulties in interpersonal relationship. So the initial investigation, so this is something that you have to do for patient with chronic abdominal pain, which is full blood count, CRP or inflammatory markers, liver function test, celiac serology, stool calprotectin, ultrasound or CT if clinically indicated, and endoscopy if alarm features are present. And when the tests are negative, then you can consider disorders of gut-brain interaction. So there's a lot of algorithm that suggest that do suggest how we approach chronic abdominal pain. But basically, what I would like to highlight from this is there's a few symptoms that is usually suggestive of functional abdominal pain. Bloating is is one of it. Usually bloating is quite sensitive for functional abdominal pain. Correct me if I'm wrong, Prof. Okay. Wall pain is also one of it, and if there's any other positive IBS symptom criteria, which I would talk later, then you also have to think about functional abdominal pain. But I'm not going to talk too much about all the investigation in ruling out organic disease. That is beyond the scope of this talk.
Yeah,
And what about
sorry, Zami, just to
uh,
mention about bloating.
uh,
In fact,
uh,
bloating is very common
mm,
among Asians
mhm,
and often described in different terms.
mhm,
Uh, so like culturally, even in Kelantan itself,
mhm,
right?
mhm,
Patient here will sometimes tell you it's angin.
mhm,
Sometimes they tell you it's, for example, senok. So they give this kind of term to describe bloating.
mhm,
But if you look at diagnostic criteria of IBS,
mhm.
bloating is not in the diagnostic criteria.
Correct.
But
Yeah.
yet,
Mhm,
bloating is very common.
mhm,
Also, last time we used to do a survey among Malaysian. This is an um, survey using social media, the Facebook.
mhm, mhm,
And in that survey, surprisingly, it's
mhm,
like almost 50% of them
mhm,
would have reported bloating at some point of time.
mhm,
And many of them associate bloating with stress.
mhm, mhm,
So again, is corroborating with what you say lah. Bloating to some extent is maybe a features
mhm,
suggestive of functional origin.
mhm. Yeah,
Yeah.
correct. Yeah, yeah, I agree, Prof. In fact, I totally agree with you, Prof. You've pointed out one thing about IBS. It is not in the diagnostic criteria, but somehow the symptoms are very, very common in in irritable bowel syndrome patients, or functional abdominal pain for that matter. Uh, so what about exploratory surgery? So most literature says that you have to avoid exploratory surgeries in chronic abdominal pain syndrome, and the surgery may increase the pain. Which when we got back to our case studies, the symptom actually got worse after the appendicectomy. So as much as we would like to get to rule out the organic cause, and we tend to fall into this trap that we may be missing something, and diagnostic lab may be helpful, especially if we're thinking about a diagnosis like adhesion colic, for examples. But as a matter of fact, the surgery might make the symptom worse. So this is something that we need to learn to learn to resist doing, not out of habits lah. I mean, some patients may need surgery, but if you don't think it will help, try to resist requesting for surgical consult just for this routinely. So if it is when it is not organic cause, when we're thinking about functional cause, uh, the nomenclature and the naming of the syndrome is quite important, because it kind of guide our treatment pathways later on. So when the pain is linked to defecation, altered stool consistency, or defecation, it is most likely irritable bowel syndromes. But if it is discomfort is located in the upper abdomens and the symptoms are related to eating, then it's most likely functional dyspepsia. Uh, so the thing with centrally mediated abdominal pain syndrome is this is a functional abdominal pain where the pain is the predominant features. It's constant or nearly constant pain with minimal association with eating or defecation. And then the pain, and if the pain is worsening and increasing with opioid doses, the patient could have been going into the narcotic bowel syndrome. It is quite important for you to make sure that you are not missing anterior cutaneous nerve entrapment syndrome. And this is something that I'm going to talk about this later. So, what leads to functional abdominal pain? And while doing this presentation, I found a good. This is a correspondence letter to the editors lah. So. They actually do this study where they have a questionnaire. They give a diagnosis. Basically, if the question is if you had a leg weakness and your tests were normal, and a doctor said you had, for example, the doctor said that your symptom was all in the mind. Would he be suggesting that you were either putting it on, whether you were mad, whether you were imagining symptoms, whether you were having medical conditions, or whether you are just looking for reasons of work? These studies are done among 86 new neurology patients, and they come up with these terms: number needed to offend as opposed to number needed to treat. So they found out that if you had leg weakness, and the doctor said that the symptoms are all in the mind, the number needed to offend was two. But if you tell the patient that you had leg weakness and the functional and the your test was normal and you tell them the patient had functional weakness, the number needed to offend was 9.
Mhm.
So the wording is important. The wording is important because if they think that you if the wording is not right, the patient may not be complying to your treatment later on. Yeah. Uh,
Yeah, I think it's very important,
uh, uh,
especially in our kind of patient that we are dealing, right?
mm-hmm,
Hizami,
mm-hmm,
in our functional GI patient and also
mm-hmm,
our brain gut
mm-hmm,
patients.
mm-hmm,
So we have a lot of such a patient
mm-hmm,
where they have symptoms,
mm-hmm,
but when you tell them something that they don't want to hear,
mm-hmm.
that's when they will just walk away. They will not listen to your explanation. They will not um, really want to go on with your treatment.
Yeah.
Yeah. So
Mm-hmm, mm-hmm,
exactly like you say, communication skill is an integral part of our management. So we need to understand how to talk to them
mm-hmm.
and how to listen to them.
Okay. So yeah. Number needed to offend. So the proposed mechanism. We can talk to this for hours. Because but there are some common theme in regards to the mechanism. So there are hypervigilance where the patient has excessive focus response to the symptoms. There's hyperalgesia where a decrease in the stimulus intensity required to elicit or there's a decrease in the stimulus intensity required to elicit or maintain nociceptive activation, or there's an exaggerated response to the stimuli, and the patient and there's allodynia where there's noxious response to an innocuous process. The Rome Foundation, basically who is responsible for coding the functional GI disorders, uh, came up with these patients education slides where there's this pain gate control theory where the pain or whatever symptoms that is in the functional GI disorders is due to the defective pain gate control. So because the pain gate is defective, any innocuous or normal stimuli to the bowel may cause exaggerated response. So this cause a lot of this is the one that causes pain in this kind of patients, the so-called brain gut axis. Yeah, to put it in the simplest term. So there's also this broken fire alarm theory, uh, f- where if a patient has IBS, there's peripheral sensitization and visceral allodynia. The volume is turned right up. So there's central sensitization, there's allodynia and hyperalgesia, and then the off switch is broken. So there's faulty CNS gating and descending inhibitions, and it's driving the patient mad.
Okay.
So it's like a fire alarm that has been uh, ringing for non-stop. You got so annoyed, and it's driving the patient mad. Yeah. So, in a way, just to put it in the simplest term, it's a wiring problem of the gut. It's not a plumbing problem. And most of especially myself, when I start training, we do focus on plumbing rather than the wiring. So we have to change our way of thinking in order to deal with this kind of patients. Yeah. So there's also the biopsychosocial models. I think those who were training in neurogastroenterology and mortality will know these models very well, where there is this interplay between the CNS, where the psychological factors such as anxiety, depression, somatization, life stress, coping mechanisms, or any structural brain abnormalities do can can cause alterations in other modalities such as the physiologies, and then there's also early life genetic and environment factors such as social support, social learning, abuse and trauma, which can also alter our wiring in the brain, which can lead to functional GI disorders presentation, and which can also affect the outcomes. So now we are going to come to centrally mediated abdominal pain syndrome. So the diagnostic criteria, according to Rome, must include all the following: continuous or nearly continuous abdominal pain, only occasional relationship of pain with physiological events, pain limits some aspect of daily functioning, the pain is not faint, and the pain is not explained by another structural or functional GI disorders or other medical condition. And the criteria has to be fulfilled for the last 3 months, with symptom onset at least 6 months before diagnosis. And there's a small print where the SCAPS is typically associated with psychiatric comorbidities, but there's no specific profile that can be used for diagnosis. Some degree of GI dysfunction may be present, but the main thing is in centrally mediated abdominal pain syndrome, it is pain predominant as opposed to other functional GI disorders. For example, irritable bowel syndrome, where there's a lot of emphasis on the change on its association with defecation. So there is no clear triggers, but some clues that can guide us towards the diagnosis of CAPS is there can also be a concomitant history of other chronic painful conditions such as fibromyalgia or other medically unexplained medical disorders. There can or can there can be history of analgesic use or sometimes there's none, but most of the time there is history of opioid exposures. So this is basically another algorithm which is basically telling the same thing on how do we arrive to the diagnosis of centrally mediated abdominal pain syndrome. And this is some symptoms related behavior which is common in centrally mediated abdominal pain syndrome. For example, they tend to have urgent reporting of intense symptom. They seek healthcare frequently. They express pain of varying intensity through verbal and non-verbal methods. They will come and they will request for diagnostic studies, X-rays, ultrasound, or CT, for example. They are so focused on getting complete relief of symptoms. And sometimes they request for narcotic analgesics. They minimize a potential role for psychosocial contributors, and they take limited personal responsibility for self-management. Some of these are present in our in our initial case study patients, yeah. For
Yeah.
example, this focus on complete relief of symptoms, yeah, urgent reporting of intense symptom, yeah. For example, whenever the patient is admitted, one of us will get texted
Yeah.
requesting urgent to be attended urgently.
She, in
Would you
fact,
agree,
she
Prof?
texted me. Yeah, she has been texting me for the past 3 days. You know, remember when you said you were away, you said she was improving after the inguinal block or something like that. Then that night she texted me already. She said
Yeah.
she's very, very painful. Then the
Yeah.
next morning she texted me again.
Yeah.
Then so I was like, I got
Yeah.
frequent texts from her.
Yeah. Yeah. So surprisingly, this is well documented. So somehow it fits the behavior of somebody with centrally mediated abdominal pain syndrome. Uh, I found this when I was doing this presentation. So this is called Carnet sign. So uh, this Carnet sign is basically a test where to rule out abdominal wall pain. So what you do is when a patient has abdominal pain, if the you ask the patient to tense up the abdominal wall. So you ask the patient to either lift the head or lift the leg. If the pain is unchanged or increased when this maneuver is done, so it is mainly due to the abdominal wall pathologies, for example, anterior cutaneous nerve entrapment syndrome, which our patient doesn't have. Yeah. So the management for this is different. So this kind of patient blocks may be helpful. Uh, and but in But otherwise, in functional abdominal pain, the examination is very much non-specific. Some studies says hot water may be helpful, but I've never tried it, so not sure whether we should be doing this anytime soon. And remember that I've talked about opioids making things worse. So there is this phenomenon called saw and crash. So when a patient with a functional abdominal pain came to emergency department, for example, they will have opioids. So these opioids will lead to this vicious cycle of worsening abdominal pain. So the patient get narcotics. They will have a bit of pain relief. This pain relief will lead to delayed GI transit, will lead to constipation or ileus, and then they will have abdominal distension, nausea and vomiting, increased intestinal spasm and pain, and then they will request for another narcotics. So it's a vicious cycle. So something called saw and crash. So this is called narcotic bowel syndrome or opiate-induced hyperalgesia, and the treatment for this is different. Yeah. So how do we manage this? So the key principles is number one, establish therapeutic alliance and shared responsibilities and set expectations. Uh, so ask the patient, how can I be helpful to you? And what exactly do you want to? Which part of your problem do we want to address? You have to provide clear explanation of the diagnosis and somehow tell the patients that uh, you have to tell the patients that you know in your case, we may not be able to get to the bottom of the problem, but you came to us for the pain. So we have to be focused on getting the pain improved. And you have to set a certain expectation. We may not be able to get your pain to be completely gone, but if we can get it to maybe 1 out of 10, 2 out of 10, where the patient can resume daily activities and they were happy with the symptom control, that is good enough. So, I mean, if we manage to get the patient on board with our treatment plan, they were more likely to be compliant to the treatment, and we will have a better outcome for the patients. Yeah. So you always focus on the functional improvement. So the keyword here is functional improvement rather than as opposed to treating organic cause where we treat the underlying symptoms. Yeah. And quite important is we have to avoid repeated unnecessary investigation because it is just going to feed into their into their unhealthy behaviors, and then and later on it will just make things worse. Yeah. So some of the treatment options that we do have, for example, tricyclic antidepressants, SNRIs or gabapentinoids, and non-pharmacologic treatments such as cognitive behavioral therapy, gut-directed hypnotherapy, or stress management. Uh, so some pharmacological treatments that can be that is suggested. So in terms of simple analgesia, there are limited benefits. In terms of opioids, one thing about opioids is we have to resist the temptation to escalate because of the narcotic bowel syndromes. Benzodiazepines may be helpful in those with concomitant psychiatric or anxiety disorders. And in terms of neuromodulators, so the thing with neuromodulators, there's a lot of neuromodulators, and the way to use neuromodulators is based on the symptoms and based on patient symptoms and what we are actually trying to treat. For example, if it is anxiety, depression, or phobia predominant functional GI disorders, SSRI might be a good example. If it is pain predominant FGIDs, then the choice of neuromodulators is TCAs. And if this is insufficient, we augment. We can use delta ligand agents such as gabapentin or pregabalin, or atypical antipsychotics. I've never had experience with this. Uh, and then non-pharmacological treatments such as cognitive behavioral therapies or hypnosis, which can augment our the treatment of our patient. Yeah. So I found these slides, okay, basically saying that the reason why TCA is so effective is because it actually targets a lot of receptors. Yeah, your histamine, your SRIs, your NRIs. So because of this remains the first line of first choice neuromodulators for pain predominant FGIDs. Yeah.
The only
Uh,
problem is
mm,
amitriptyline because
mm,
it's
mm,
acting on so many receptors, it
mhm.
can also cause many side effects.
Yeah,
So that is,
correct, correct.
yeah, that's the downside.
Mhm,
So it's just like
mm,
you are
mm,
throwing a drug that will
mhm,
target most of the receptors,
mhm,
therefore most symptoms will respond. But at
mhm.
the same time, you are also inhibiting a lot of receptors that will cause
Mhm.
different side effects. So that's
Okay.
why TC is a very
Mm,
um it it can be effective, but it can
mm.
also be ineffective,
Yeah, yeah,
so
yeah.
to speak.
Correct, correct,
Mm-mm.
correct. Agreed, agreed. Yeah. So, so it is actually I kind of want to highlight that it is very important for you to frame this medication as a neuromodulators and analgesics because if they found out that this medication was used in depression, for example, they are very reluctant, and the patient, and you kind of stigmatize the medication for the patient. Yeah. I usually we kind of have to tell them outright that we are using this medication for analgesia, even though this medication is used for depression, and the dose for neuromodulators are very very low, 10 to 25 milligram of amitriptyline, as opposed to the dose that we use in depression, which can reach up to 200 milligram. Yeah. So so the last thing that you want to happen is you give this medication to the patient. They found out some time later from other sources that this medication is an antidepressant, and they are very unhappy about it. Yeah. So you have to tell them quite clearly that this is analgesia, and we are using this medication as such. Yeah. So and you really have to make sure to monitor the side effects. Yeah. Such as anticholinergic effects, sedation. The most common symptoms, at least personally, that I've encountered, is basically sedation. They tend to be very very tired, and most of them choose to stop it by themselves because they said they cannot work. Yeah. And then sometimes it can cause hypotension, palpitation, or constipation. Anything else? Any other side effects that you have encountered, Prof? When you're using TCA for these patients?
Yeah, so
At
you're
least.
right. The
Uh, uh,
sedation is
mm,
definitely the most common.
mm,
And it's good that you highlight constipation
mm,
there
mm,
because we do use a lot of neuromodulators for
mm,
IBS.
mm,
So if the patient is constipated,
mm,
then this will not be a good choice.
mm,
Yeah. So I think just
mm,
have to be careful.
mm,
We need to understand that the drugs, the neuromodulators, they
mm,
may have differential effect
mm.
in the brain and also in the gut.
Okay.
So we need to understand those differential effect in order to use the right choice of drug in managing the right symptoms now. Mm.
Okay. Okay. Got it.
In fact,
Mm,
there is another
mm,
version, a
mm.
much safer version of amitriptyline. We call it nortriptyline.
Oh,
But
non-tryptophan. Yeah.
but unfortunately, this drug is not available in
Mm,
Malaysia. It's
mm,
available in Thailand though. So my
mhm.
Thai colleagues use this drug quite a lot.
Okay. Is it
Mm.
less sedative, Prof?
Less sedative, less
Sedative.
anticholinergic effects.
Mhm. But
Yeah,
but the neuromodulating properties are almost the
just
same.
as
Just as good.
yes,
Just
just
as
as
good.
good.
Okay, sure. Okay. Okay. So so I've talked about augmentation medication. So the thing with augmentation medications is it allows lower dose of medications prescribed. So for example, instead of giving a high dose amitriptyline, you can augment it with Lyrica or pregabalin, for example, and and it allows you to use a lower dose of this medication, and in a way reduce the side effect profiles. Yeah. And at the same time, it kind of augments or enhances the effect of the drugs used together. So this is especially useful in refractory GI disorders. Yeah. And then we come to behavioral therapy options. I've limited experience with this, but in all these behavioral therapy options, basically is designed to address a certain basically it's designed to address a specific complaint. For example, cognitive behavioral therapy for the hypervigilance, the mindfulness-based stress reduction for this fear, for this phobia or fear of symptoms or attentional bias, yeah, relaxation training for your visceral hypersensitivities, your gut-directed hypnotherapy, which can be useful for hyperalgesias or somatization or extra-intestinal symptoms. But this will require a multidisciplinary approach, something that we need to work on lah, basically in many centers. Mm. So the key teaching points is basically chronic abdominal pains requires structured evaluation. The alarm features must be excluded early. The negative investigation should prompt consideration of gut-brain disorders, and basically centrally mediated abdominal pain syndrome is a centrally mediated pain disorders requiring multidisciplinary care and multimodality treatment. And with that, I'm done.
Oh, well
Anything?
done.
Okay, anything, Prof? Anything to add, Prof? Mm,
I think this is a great
mm,
overview of
mm,
chronic abdominal pain
mhm,
of functional origin. So,
mm,
like you said, you need to follow a structured
mm,
workflow
mhm,
from exclusion of organic diseases.
mhm,
But one thing is that we should not stop labeling, or we should not just not use the label of
mm.
a functional GI disease just because we couldn't find any organic disease.
Yeah.
You see, what happened in a lot of GP setting is
Mhm,
they for some reason our doctors are reluctant to make a diagnosis of irritable bowel syndrome or
mhm,
functional dyspepsia.
mhm,
They would go all out to find
mm,
a organic condition.
mhm,
Until they find an organic condition,
mhm,
they will not they will not stop doing tests to find that out.
mhm,
And yet the patient wasn't given any diagnosis in the meantime.
mhm,
So patient got frustrated
mhm,
because it was not properly communicated. The doctors keep on doing tests. So
mhm,
there was no treatment also
mhm,
given just because the doctors think that there must be some organic condition, but yet they were not given a label.
mhm,
Instead,
mhm,
what should have happened is we should give a patient a label of functional GI diseases based on the diagnostic criteria,
mhm,
treat the symptoms. At the same time, we can watch out along the way if there's any organic disorder that manifests. Because
mhm,
sometimes the disorder may only manifest later. But in the meantime,
mhm,
we should give an appropriate label
mhm,
for the patient in order for us to manage the symptoms
mhm.
properly. That will lead to better expectation and less frustration on the
Okay.
patient side.
Okay. Agree.
Mm.
Yeah, yeah,
So
yeah.
that would,
Mhm,
yeah, that
mhm,
would be one.
mhm,
And of course,
mhm,
psychological assessment is always not very well
mhm,
or assessed in practice.
mhm,
Many of our students also did not really look or even ask patient what are the psychological problems,
mhm,
right?
mhm,
And also we seldom ask about quality of life and so on.
mhm,
Disturbance in sleep.
mhm,
Yeah, sleep also is another important history that a lot of time we did not ask. Like in this patient,
mhm,
if we have known that she have a really poor sleep, then probably from the start, if we have already started something like agomelatin, it would have already improved her sleep status, for example.
Yeah.
Yeah. In fact, sleep is very frequently affected in patients with functional GI disorders.
Mhm.
Yeah. So
Okay.
this is another one.
Mhm.
Yeah, I mean, well done,
Yeah.
Hizami. Good.
Yeah.
Maybe you can ask Jasmine or Wong if they have any questions or any patient that they encounter in their practice.
Prof, just want to ask, how's your experience dealing with psychiatrists and psychologists for this kind of problem? I'm talking from somebody who has worked in Ministry of Health. So, whenever I'm dealing with this kind of patient and I started amitriptyline, for example, I would invariably will get a call from the psychiatrist saying, why are you using this medication for such and such? And then when I talk to them in regards to, cognitive behavioral therapy, they are not very comfortable dealing with this kind of patients. So, how do you get the psychiatrist or the psychologist on board managing this patient? I understand that we have a very good team here, but if for example I'm going to start this service later on at a place where there is where they are not used to dealing with this kind of issues, how would you approach that, Prof?
Yeah, I think
Uh,
this is a very
mm, mm,
important
mm,
question
mhm,
because most of the
mm,
time, our
mm,
psychiatrists, they are
mm,
managing more psychotic
mm,
conditions
mhm,
than psychosomatic conditions.
mhm,
So they may not understand that actually
mm,
in many of the chronic diseases, including GI,
mm.
even nowadays neurology, they have a term called functional neurology. So
Oh.
they
Mm,
may not understand that
mm,
many of these chronic
mm,
conditions chronic disorders
mm,
can have psychosomatic diseases.
mm,
But many of our psychiatrists
mm,
in the hospital, they are dealing more on psychotic. So there is this psychotic neurotic issues that
mm,
or dichotomy
mhm,
that wasn't very well addressed.
mhm.
Also, there's not many psychologists in the even in Malaysia we are having inadequate number of psychologists because the one that really administer
Mm.
all this cognitive behavior therapy would be the psychologist.
Ah, ha, 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 ha.
Yeah.
Mhm,
Which is why I think capacity building is important.
mhm,
And for the past few years, there are more institutions offering clinical psychology in Malaysia with the hope that we can have more people trained to be a psychologist. But
mhm.
in the meantime, while we are waiting for the numbers, physician like ourselves, we should manage our own patient with psychosomatic disease. We are the one who understand
Mhm.
why this patient manifests GI symptoms. But psychiatrists may not understand that,
Okay.
right? So
Okay.
all the more important, we should be
Mm.
trained
Mhm.
in some psychological assessment and also
Okay.
psychotherapy and
Mhm.
neuromodulators in
Mhm.
order for us to treat our patients better because we understand our patient better
Mhm.
than the psychiatrist.
Understood. Understood.
So we should work with them lah. They
Yeah, yeah.
shouldn't be say the psychiatrist shouldn't say that this patient belong to them, but
Okay.
really it's about all management of the patient together.
Mhm.
And
Mm.
we also need to make our psychiatrists understand that we understand our patient better because they manifest GI symptoms, and we are the better physician who can manage that them.
Yeah. Understood. Thanks for that,
Mm.
Prof. Yeah, yeah, yeah.
Yeah,
Yeah.
if you ask many of psychiatrists, they may not heard of a
Mhm.
gut-brain axis also.
Yeah. I think this is a problem that we share among all the fellows and gastroenterologists lah. We really have no idea how to get them on board. But you're right, Prof. I think in the end, it is us that has to take the responsibilities for all this lah, Prof.
Yeah, we
Uh,
take the
uh,
first responsibility and then we work
uh,
with the psychiatrist.
mhm,
We can build up a
mhm,
team
mhm,
like what we have done here. We got this so-called gut brain clinic that
mhm,
we
mhm,
run
mhm,
um, as a multidisciplinary team.
mhm,
So that will be the ideal because many of the condition
mhm,
can be quite complex. It's beyond just giving drugs.
mhm,
Our psychiatrists, they are very good in prescribing drugs,
mhm.
but drugs is not the main solution. It has to be holistic. We need
Yeah.
to understand how to manage the GI symptoms, which they
Mhm,
may not know how,
mhm,
but we know and we understand the pathophysiology.
mhm,
So we should be responsible for our own patients.
mhm. Okay. Okay. Good point, bro. Um,
Any other
any other
questions?
questions?
So Jasmine and Wong, they are very quiet.
Just
Uh,
taking
they,
it all in, Prof.
All right. Do you
Okay.
think it's too difficult for you all, or
Mm.
do you see some of this patient in your practice? Jasmine?
Sorry, Prof. Can you repeat that?
Yeah. So do you see this kind of patient in your practice? And do you think this talk will somehow enlighten you or open up about gut-brain axis and so on?
I believe that this would be one of the first few cases that I've encountered, which is pretty evident that there is some element of gut-brain axis. I've not myself experienced or seen any patients similar to this before, actually, Prof.
Mm. And I suspect we're going to have more and more such patients because our mental health disorders, right, are on the rise.
Yeah.
We are in a society where metabolic disorders
Mm.
and mental health disorder will be increasing. Just it's going to be very different from the past, where I think in the past, right, our parents they were more psychologically resilient compared to our younger adults nowadays.
Mm.
Mm.
I
Okay.
I cannot disagree with that. I agree.
Right, that's good. All right, Izami, Jasmine, and Wong, if there's nothing else, I guess we can end the session today. Yeah.
Okay.
Prof, today we have a CPC at 2:30. Is via online link as well
Okay, sure. I will
with the
definitely,
pathologist.
yeah, you can definitely join in. They may ask us about the patient, right? So you can present the same sequence of events though for this patient.
Yes, I've prepared the slides as well.